I'll preface this real quick and say if I offend anybody in any way, any shape, form today, I apologize right now, okay? Because I'll guarantee you I'm going to offend somebody, and I don't mean to do it. It's just I have two processes. Sometimes things roll around in my head and then they come out my mouth, and other times I skip the first part of the process. Okay, so you just have to understand me. I'm a little bit different. I'm wound a little bit tight, I guess, at some point in time. My name is Rick Proctor. I am the Director of Clinical Education for Chattanooga, and I do get to teach about modalities. That's the thing. For 26 years, I taught them in higher education. I've used them. My doctoral degree is in biomechanics and human physiology, and I got this background in physics, and if you put physics and physiology together, that's where modalities live, right? And so it's right in my wheelhouse. So I've taught PTs, OTs, ATs, modalities forever now, it seems like. So I'll be 65 in June, and all bets are off at that point, okay? So this could be a swan song. So here's my thing. When I start talking about modalities, the first thing I ask you to do is I ask you to think differently. Because you've been taught that we use what we get reimbursed for. We got to get paid. And it makes sense. I understand. We have to make money. We have to make things work. So what I want you to understand is that I'm going to ask you to think a little bit differently. And I want you to know that, some people in this world will tell you to think outside the box. You ever heard those people? I'm not that guy. I'm the guy that's going to tell you to throw the box away. Okay? Throw the box away. Don't even think in terms of the box. Because what we've got to do is we've got to use it. You know what the second part of that quote was? That without knowledge, without imagination, there is no future. Right? He also said insanity is doing the same things over and over again and expecting a different result is insanity, and it is. But we do that, don't we? Patient comes in, we have a protocol. Now I'm going to tell you right up front about electrotherapy. My pet peeve, do you have a protocol? Yeah, I got all kinds of protocols, but you got all kinds of disorders and you got all kinds of patients. And the bottom line is, my protocol is not going to work for every patient. One size does not, never has, never will fit all. Am I right, ladies? You go to the shoe store and all they got is a 7. How's that working for you? Right? So you got to understand that we got to think differently. We got to do things a little differently. And we have to ask ourselves, why do we even use these things called modalities? Why do we even talk about modalities? And then you have to ask the converse of that, well, what keeps you from using them? And I hear people say this all the time, and they talk about patient barriers. Well, my patient doesn't like the way it feels. Well, if you didn't do anything that your patient didn't think felt good, how good would your patients be? Right? We have to push people past where they are. We have to push them to the point to where their bodies will adapt and they will get better. And that's what we kind of do. We have therapist barriers. You know what your biggest barrier is time. You're expected to treat more patients and do more things with less than you've ever done in your life because you can do it all. You're miracle workers. That's what they think. Okay? I know. Been there. I've seen this. I've done it. So I know your time is one of those things that gets in the way. How do I do this? What if I showed you a couple of ways that you could put on a modality and save some time? All right? We're going to do some crazy stuff. I promise you we are. These are things that get in people's way, and I love this because all those things on the top, I can fix. I can get you better equipment. I can teach you how to use it. I can do all kinds of things. I can help you with the product itself. I can't fix those two. Those are a state of mind, and that's something you have to fix. You have to get the idea that yes, it will help. I don't know how many people tell me over and over again that electrotherapy doesn't work. And I'm going, how do you know that? Because there's no research to back it up. And it was kind of like, either you don't know how to read, or I found something that's a gem, in a mine here. I found this golden nugget. Because the bottom line is, somebody asked me one time, said, do you have any research on muscle strengthening, muscle re-education, and electrotherapy? Okay, what do you want? So I promptly sent them 1,000 references. You know, I got this little reference list and just copy and paste and done. Here we are. So when we talk about things that get in the way, those two right there are on you. They're not on me, they're on you, okay? So the question is today, what do you want? Why are you here? What do you want out of this? Because this is about you, it ain't about me, okay? This is about you, and I want to know what you want. And I'll tell you what you want for your patients. You want outcomes. You want your patients to get better. You want your patients to be able to do the things that they were doing before. And I'm going to explain something to you very quickly. You don't fix things. I want you to get that. And I'll explain more about this in a minute. You don't fix anything. What you do is create an environment. And what you do is help a patient get to the point that they can do their activities of daily living in the best possible way they can. You don't fix things, you create opportunities for people to do the things they want to do. And I'll explain more in a minute. I love looking at research, and I love looking at bad research. This is some of the worst research on the planet. And we're not talking about ultrasound today, but I want to show you this. If you look at this case study, the title of the article, or the undertitle of the article, was Ultrasound versus Sham, No Relevant Benefit in Treatment. Okay? And the bottom line is, when you looked at all of this, they had a patient who had adhesive capsulitis of the shoulder. Now everybody knows what that is, right? That's a deep tissue, isn't it? So if you're going to use ultrasound on a deep tissue, what frequency of ultrasound should you use? 1 megahertz. What'd they use? 3.3. By the way, it also says if you're going to treat with ultrasound, how big of an area can you treat? Twice the effective radiating area of the transducer, right? About that big. Do you see how big of an area they treated? They started here, and they went here, and they went from back to front. They used the wrong frequency. They did the treatment completely incorrectly. And it didn't work. Well, really? No kidding. Anybody that would have expected that to work is just totally out of touch. So the bottom line is, watch what you're reading when you read this stuff. Make sure you read more than just the little abstract. Read the results. Read the stuff so you know exactly what happened. So you have to look at some of these things. This is something that I really like. This is an acronym that I use, and I will tell you, I wish I could say that I made it up, I created it, I didn't, I stole it from somebody, okay? Most everything that I have, somebody else created, and I took it from them, and I use it myself. But that's what we do, isn't it? We share. And that's what this is all about. But we talk about PASS. We talk about pain, alignment, stability, and strength. And if we can do those 4 things, if we can solve those 4 issues, we now create solutions to problems. That's what this is all about. It's not about putting on a modality. It's not about doing a specific exercise. It's about creating a solution to a problem. And that's what I want to do, is create solutions to those problems. Because if we look at those solutions, we call them outcomes, right? And so we now talk about, if we get rid of pain, if we increase range of motion, stability, strength, and function, guess what you just did for the patient's quality of life? I didn't fix anything. But what I did was provide an opportunity to enhance the patient's quality of life. That's what this is all about. That's what this is all about. Keep everything in perspective. So we're going to talk electrotherapy. Now, if y'all look at that statement right there, how many of you would say that's true? Pretty much is, isn't it? That's what people use electrotherapy for. There's the missed opportunity. You see the missed opportunity? Muscle re-education, muscle strengthening. Increases in circulation, increases in range of motion, decreases in inflammation. I can accomplish all of that with electrotherapy if I use it correctly. If I use it correctly. And so all of these things, they're indications yet, but I call them missed opportunities because we don't do it anymore. And we have this excuse, well, we don't get paid for it, and then the next excuse is, well, it doesn't work. But it does, okay? So let's talk about electrical stimulation, and let's talk about these missed opportunities. Let's talk about how to fix things, right? So everybody's going to tell you, you're going to put 2 electrodes on a patient. Where do you put the electrodes? Somewhere where the problem is, right? Usually we put either 1 electrode on the problem and 1 away from it, or we put the problem in between the 2 electrodes, but we put the electrodes where the problem is, okay? So when people start asking me, do you have pictures of where I put electrodes? Do you have pictures of your problem? I'm sorry, I told you I'm going to offend somebody, and I apologize. But the bottom line is we put the electrodes on. We take that current, we run that current down a wire, and it runs in 1 electrode. That current will then go through the body. It uses the body as a conductor, and that current will run from 1 electrode to the other electrode. And everything that is underneath and in between those 2 electrodes is what gets treated. Okay? We are looking for a physiological response. What are those physiological responses? Now understand this. Electrical current directly affects nerves. It indirectly affects muscle. It indirectly affects other tissues, but it directly affects nerves. So when you turn it up and you turn it on, the first thing you tell any patient is what? Tell me when you feel it. And when they feel it, that's what we call a sensory response. We have now stimulated a sensory nerve. Sensory nerves are unmyelinated for the most part, so that's why they get stimulated first. They're real easy to get to. They're real easy for this to happen, right? So we stimulate a sensory nerve. They feel something. There are some protocols that you turn it up until they feel it, and that's it. Okay? But if I want a muscle contraction, I now have to turn it up until I hit a motor nerve. Motor nerves will be thinly myelinated, some a little heavier myelinated, but they're a little more difficult to stimulate. In the tissue, they're a little bit deeper. So we got to turn that amplitude up to get more power to stimulate that motor nerve. And when you stimulate that motor nerve, you'll see a contraction, right? Whether it be a twitch or whether it be a contraction. The problem is you're still stimulating that sensory nerve. And if you keep turning it up and you're still stimulating that sensory nerve, the patient more than likely at some point is going to say, ouch. Now let me say this. Electrotherapy is not meant to be painful. It's meant to be uncomfortable if you're doing certain things, but it should never be totally painful unless you're trying to stimulate a noxious nerve or a pain fiber. They're very small, they're very highly myelinated, so it takes a lot to get to them, and if you turn it up, yeah, you can make it hurt. There are some protocols that require pain to be treated with electrotherapy. We don't use them most of the time. Why? Patients don't like them. And if a patient doesn't like it, they don't come back. If they don't come back, we don't get paid. You see a theme? And this is what I call mass confusion. Is this not where the rub comes with electrotherapy? This is where the problem is. Everybody goes, which one of those do I use? Now I'm going to ask you a question, but before you answer, I'm going to tell you, before you answer, I'm going to tell you the answer. What waveform do you guys use if you use, I should ask this question. How many of you actually use electrotherapy on a daily basis? That's great. Wow, things have gotten better since COVID. I'm just kidding. Of all of you that said you use electrotherapy on a daily basis, how many of you predominantly use, say that out loud,
IFC.
Interferential? Why? Can somebody tell me why you use interferential?
It feels good.
Okay. I've heard some people say opposite. But why do you use it? Here's the answer to the question. It's what you were taught to use. It's what everybody uses. Now let me tell you something. Do you realize that Blue Cross Blue Shield and Aetna do not reimburse for the use of interferential current? And do you know how you bill it? Do you know how you code it? You code it as electrotherapy. You don't code it as interferential. If you ever get audited and they ask you what you used, they're going to ask for money back. That's one of those little known facts, and I'm not charging you any extra for that. That one's free. Okay? So the question is, which one do I use? Now, I'm going to tell you real quick. You see, what are there, 12 there? I can't remember, but there's a number there. You go to Europe, and they've got over 30. They've got over 30 that, we use this, we use that. I'm going to tell you right now I use 2. I'm not going to tell you which ones, we'll get there in a little bit, but I use 2 of those. To me, we spend too much time teaching a waveform. We spend too much time talking about electrotherapy and those parameters that are surround a waveform, when we ought to be talking about what's the physiological response, right? So I want you to look at it from that way. There have been several studies done. They did some studies about interferential current. They've compared it. They've looked at different things. They looked at Russian, and they talked about the fact that, how phase duration is manipulated or changed here. And in this case, when you look at this study, IFC and Russian, phase duration is fixed. You don't manipulate it. You don't change it. Again, another study was done. Notice this. Do you know, first of all, there are certain people that would look at the Snyder-Mackler study of 1989 and say that research is too old, it doesn't count anymore. You ever heard that? If it's not within 10 years, it's not good research. That's some of the best research that's ever been done. I mean, this was a classic. And then, of course, what Scott and Solkowitz did is they redid the same study years later, but I guess it's out of date by now. So, you start, you get to a point to where people are doing the same research over to prove the same point. And again, they did the exact same thing, and they showed that IFC, because of phase duration, has less ability to produce muscle torque. So you really don't get a muscle contraction with it. You can get a muscle contraction, but not strong enough to create strength. So guess what? IFC is used for pain. What do we treat more than anything else? Pain. But what if I told you we could treat other things and take care of the pain in the same time? We did something different. I'll show you some real cool stuff. So here's my thing about electrotherapy. We make it too hard. I used to teach a course called The 6 Simple Things. 6 things you needed to know about electrotherapy. I've now pared it down to 3, but you'll notice I'll talk about the other 3 in here. But there's still 6 things, but we talk about 3 things. If you can adjust those 3 things, you can do anything with electrotherapy you want. Did you realize that? If you can adjust those 3 things, you can do anything with electrotherapy that you want. Frequency, amplitude, and phase duration. That's all you need. I don't care what waveform it is. Please understand, it's the physiological response I want. I want you to know that your body does not understand, your tissue does not understand the difference between interferential, Russian, and symmetrical square biphasic. Your body does not know the difference. What it does know is that there's an electrical current that has 3 properties to it, amplitude, frequency, and phase duration, that will give those physiological responses. Okay? So this is what's really cool for me. Amplitude. Amplitude's how much you turn it up, right? Amplitude is what gives us our physiological response. So we turn it up until we see something happen or they tell us they feel it, right? So we're looking for that physiological response, and it's the amount of current that we get to turn it up. Now this is what another question that people will ask. How much do I turn it up? I don't know. Because it's going to depend upon your patient, right? If your patient comes in today dehydrated, it will take more current to contract that muscle than it did yesterday when they were hydrated. So there are all of these other variables that exist within the human body, the most important one being the amount of fluid that's in that body, as to how much current it will take. The other thing is, well, where did you place the electrodes? You're not going to have them placed exactly the same place every time. We can get close, but we're not going to have them exactly right. So we're going to see things slightly different. So it's not the number of milliamps I'm worried about. Turn it up until you get the physiological response. For some people, that's going to be more than others, right? How much is enough? It's like hot sauce. Y'all like hot sauce? Okay. How hot do you like it? Because I'm the guy that grows Carolina Reapers and ghost chili peppers. I dry them, I grind them, and I eat them, okay? So now I ask you how many of you like hot. You say, okay.
Why you take so much medicine?
So now we qualify that, right? Now we qualify it. So how much is enough? I'm married to this lady, the most wonderful woman on the planet. Sorry, lady, she takes first place. I mean, she's absolutely the best. Her hot is black pepper. So what's it called? It's called tolerance. There's some people you can put electrical current on and you can turn it on and they'll be bouncing all over the table. There are other people, as soon as they hear the switch click, they go, nope, stop, that's too much. Right? So we got to find a way to turn it up. And sometimes we have to lie to people and cheat, okay? I'll be honest with you. You do that. You turn it up and they say, no, stop. Okay, well, we're going to start and we're going to do this. And you reach over and you turn it up and you don't say anything. It's okay. You can do that. So, again, it's about tolerance and it's about getting people to understand what you're trying to do. So we have to do some explanation. I don't care if you understand what Ohm's law is. The one thing you need to know about Ohm's law is something called resistance. And resistance is what causes us a problem. Skin is a resistor. Dry skin is a super resistor. You put lotion on the skin, you took the super resistor and put it on steroids. Because that current's got to go through all of that, and now you've got so much current that you're going to irritate the heck out of the sensory nerves before you stimulate a motor nerve, right? So we got to mitigate resistance. If not, you wind up with a skin irritation or even sometimes a burn. That comes from using good electrodes. You have to use the best electrodes you can buy to get the best result that you want. And I know how places work. We buy the cheapest electrode we can buy because it's cheap. We got to save money somewhere, so we do it on electrodes. I'm telling you right now, it's the worst thing in the world to save money on because you're never going to make electrotherapy work on some of these dirt cheap electrodes that come out of China. I'm just saying, okay? Amplitudes, how much we turn it up. Frequency. Frequency is the number of pulses per second, right? It's how many times per second we actually deliver that current to the patient. Now, if we're doing middle frequency current, by the way, your 3 middle frequency currents are what? Interferential, premodulated, and Russian. That's your 3 middle frequency currents. We talk about that in beats or cycles per second, right? So we don't talk pulses, we talk beats, and we'll talk about some variations of some of the lower frequency currents that we talk about monophasic and biphasic currents, and then again, the pulses per second. So let's just look real quickly. If you look at this, this is 0, this is the isoelectric point, this is where no current flows, correct? And so what you're going to see, this is the negative pole, this is the positive pole. What you're going to note, in this case, the current rises from negative to positive, it comes back to the baseline. There is a hesitation, there is a delay before the next pulse starts. So this is an interval in between each pulse. You will notice it only goes in one direction, right? That's called DC current. In this case, it is pulsed DC current. It is pulsed DC current. Now I will tell you that true DC current would go up and there would be no delay. It would just continue on. There's no pulse. It's one and it just keeps going. That's what we use in iontophoresis. Okay? That is the current that we would use in contracting denervated muscle. So this is called DC current, pulse DC. Notice this one, it goes up negative to positive, it then comes positive to negative. The polarity is reversed here. So now, by the way, 1 phase equals 1 pulse, monophasic. 2 phases equals 1 pulse, is what we call biphasic. But more accurately, this is pulsed alternating current. It is pulsed alternating current because it goes one direction and then the other. And this is middle frequency. You get a series of those phases and then there's a break, and a series of phases and there's a break, and we call that a burst per second, okay? The idea is that we could deliver more power with a middle frequency unit than we could with a lower frequency unit, and we should be able to do more good. The problem is, this is where all the burns occur. This is where people get hurt with electrical current. So how do you determine frequency? There are just a few numbers you need to know, okay? I want you to understand something. If you're treating pain with electrical current, there are only two ways to do it. You either do it with a high pulse rate or a low pulse rate. Now, different people have different names for that. For example, if you're going to treat pain by the way of what I call the gate theory. Do you remember the gate theory? Right? A non-painful stimuli introduced on top of painful stimuli travels on faster pathways, therefore beating the painful stimuli to the spinal gate, right? Thus closing the gate, and the brain only recognizes the non-painful stimuli. Spring semester of my junior year, Psychology 102, Dr. Pope, Roberts Hall, room 110, okay? Remember that. Only thing I remembered from that class, but I was there. The bottom line is, the gate theory, some people call it the sensory protocol, because what you do is you turn it up till they feel it. And you want them to feel it a little strongly, so we turn it up till they feel it a little bit strongly, and we treat pain by way of the gate theory. What you're going to note is that the pulse rate is above 80. If you can modulate it, and you understand the term modulated, it means that you travel between two frequencies, 80 to 150, and then back down and back up. So it modulates, so you reduce the ability of the patient to adapt, or the tissue to adapt to the current. And so therefore you don't have to turn it up as much. But if you can't modulate it, just put it on 100 pulses per second fixed. Now, there's no magic. You could do 110. You know, you could do 103 if you wanted to. You can do, the key is you want it above 80. So we put it on, we turn it on, and again, that's the protocol where we turn it up just till they feel it real strong, bang, we're treating pain. There's a problem with what we do though. Too many times we put this on the patient, we turn it on, tell me when you feel it. Oh, I feel it. And then we say, now you sit right there, or you lay right there, and I'll be back in 20 minutes or 15 minutes or however long we treat that patient, right? And as long as that current's flowing, it's knocking down the pain, knocking down the pain, knocking down the pain, right? When that current turns off, what happens to blocking the pain? You'll get a little residual last, but it's not very long. It's only about 3 minutes, 4 minutes. So why don't we throw the box away? So now I got a patient with a shoulder pain. I put the electrodes on the shoulder. I turn it up. Tell me when you feel it. Oh, you feel it pretty good. Let's turn it up just a little bit more. Okay, now, this is what I want you to do. I want you to move your shoulder into flexion just as far as you can till it hurts, and then I want you to move it back down. I want you to go abduction. I want you to move it back down. I want you to move until it hurts, and then I want you to come back down. I want them to do active movement, if they can, while the current is flowing. Now, if they can't do it, you move it for them. It's then called attended electrotherapy. It reimburses at a higher rate, but that's not important, right? But the other thing is this. If I take a patient and the current is reducing the pain, that means that eventually the patient will begin to move more. Bless you, if they move more, they will recruit more muscle mass. If they recruit more muscle mass, they will increase circulation to the part. If they increase circulation to the part, they will increase the temperature of the part. If you increase circulation and temperature of the part, you now systemically affect pain. Now when that 15 minutes is up or 20 minutes is up, whatever you use it for, when that time is up, I will have a patient with more movement, with less pain, that will be more compliant to doing the next step in my rehab. Tell me the downside. Okay? Bill for Therex. I don't care what you bill for, but if you do the two things together, you'll get an outcome that you haven't gotten before. Okay? Throw the box away, do something different. Get them to move. Electrotherapy is not, never has been meant to be a passive device. Do you know why we made it a passive device? Do you know why it's treated as a passive device? Because in the 80s and 90s, when I'm working, we did all of those things. We used electrotherapy as a placeholder because you know why? We got reimbursed like between 30 and 40 bucks to put on electrotherapy. We got 20 bucks to put on a hot pack. We got 10 bucks to put on a cold pack. We called them the Three Amigos. Everybody that walked in got hot pack, stem, and left with a cold pack. And people made a bloody fortune. That's why it's not reimbursed anymore. It's because people abused the system. And we still do it. I'm sorry. We're code chasers. We chase the next thing that will pay us. You know, that's unfortunate, but that's the way it is. So my thing is, when we start talking about doing things together, let's do things accurately. It's not meant to be passive. We want the patient to do something when the current is on them. Unless you're treating wounds with electrotherapy, the patient needs to move. Okay? There's the opiate release. Some people call that the motor protocol because now you turn it up until you get a twitch. But you're going to notice the pulse rate is real low. So when you treat pain, it's either a high frequency or a low frequency. So now it's somewhere between 1 and 10, or just put it on 10. I don't know why I put 6 there. It's probably because I was trying to find the middle. Just put it on 10 and turn it up until it twitches. Pretty simple. And now we're going to do the same thing. We're going to have the patient move. We're going to have them do something, and we're going to control the pain. Muscle strengthening, muscle re-education. Well, there should be 3 numbers up there. There's only 2. But there's 35 and there's 50, and then the other number you need to know is 80, okay? But if we talk about muscle strengthening, we talk about at 35 pulses per second, we claim to target slow twitch fiber. Bottom line is lower frequencies, less contraction. We don't fatigue as much, so we can do endurance activities. So we assume we target slow twitch fibers. So we do utilize them a little more with that. You go to 50 pulses per second, now we say we're going to get fast twitch fiber, and what you actually see is that at 50 pulses per second, the contraction level is to such a degree that we begin to fatigue motor units more quickly, okay? So if you have a patient who has weak to flaccid muscle, we're going to go 50 pulses per second because we got to target fast twitch fiber. Why? They're the easiest to contract. They're the easiest to get to contract. It's harder to target slow twitch. If we have a patient who is just weak, then we go to the 35 pulses per second so that we can do work over time. Now I'm telling you, I don't understand why fatigue got such a bad name, okay? Because fatigue is necessary, isn't it? If you don't push a patient to the point of fatigue, they will never get past that point, okay? So we talk about 35, we talk about 50, 80 pulses per second. If you have flaccid muscle, I want you to think about this. 80 pulses per second, you have flaccid muscle. If it's flaccid, the only way to contract it is to turn that current up more, right? But sensory-wise, they don't tolerate that. So guess what I can do? I can go up 30 pulses per second and use less amplitude because I'm getting the current 30 more times per second. That means my current density went up, but my amplitude stayed down here. So I can increase the amount of current delivered to the patient simply by increasing the frequency. That's how I increase current density. So now guess what? My patient tolerates it better. There are all these others. You can do a sensory response for muscle spasm. It's 100 pulses per second. That's actually a high volt protocol. I'm a real big fan of high volt, okay? I use high volt for several things. If you're going to increase circulation, decrease swelling by an ion movement, high volt is your go-to. The protocol is always about 100 pulses per second. Again, high volt is a pulsed DC current, so therefore it has polarity. So you can literally, you can take the typical positive lead, the red lead, and put it distal. You can put the black lead, and you can put it proximal, and you can actually turn it on, and it has an ion effect where it will actually push swelling out to the next point. I'm a real big fan of doing that, wrapping and elevation and movement. If you wrap, elevate, and move with the current, I can move fluid. I can move fluid. It's crazy what you can do with it. If you want to do muscle contraction, to move edema, you can do 5 pulses continuous, which means you're just doing this the whole time. Put it on the muscle and get it to do this. Elevate, wrap. Again, we're moving. By the way, with the muscle strengthening, I didn't say this and I should have. Whenever the current contracts the muscle, we always tell the patient to do what? You have to work with it, right? Because the idea is that the current recruits motor units. I volitionally recruit motor units, so therefore I can gain strength more quickly, right? By the way, that works in healthy muscle just as well as it does unhealthy muscle. Now, I've taken it on athletes who are trying to increase their strength with squats or whatever. You put the current on the quads, and when they go down the squat, you hit the button and give them the current, and they try, So again, you're using the current superimposed on top of volitional contraction, and you get crazy results. Crazy results. It'll work on healthy as well as unhealthy tissue. But this 5 pulses per second, we do that, and we actually create a siphoning effect. You know what I'm saying? We siphon some of this fluid out of the tissues. And so then if you want to do 35 pulses per second, you can actually get the muscle to squeeze and relax. Squeeze and relax. Anything you know of that you do with your hands? It's the same as a massage, the same results as doing the massage thing, except my hands don't get tired. Okay? I don't know about you, but I'll be 65 years old in June. My hands don't do what they used to do. They hurt. Okay? So some of this stuff isn't any fun anymore. And then we'll talk about inflammation, talk about some things later on. So again, amplitude, frequency, phase duration. Frequency is how many times, right? Amplitude is how much, phase duration is how long, and frequency is how many times. So phase duration is how long the current is applied in each pulse. That's the length of time. We measure it in microseconds, okay? We do know this, that if you want to stimulate sensory nerves, you use short phase durations. So if you're treating pain by way of the sensory gate protocol, whatever you want to call it, we want really short phase durations, 100 microseconds. If you're trying to contract a muscle, you want longer phase durations. Okay? 300-400 microseconds. Don't be afraid to turn that up. If you've got that stubborn muscle that won't contract, the first thing you go to is phase duration. Again, you're applying the current for a longer period of time. So what did we just do to current density? We increased it, so now it's easier to get a muscle contraction. So we'll talk about longer phase durations with muscle contractions. This is one of those things just to show you. This is amplitude. This is the amount of time. This is the peak amplitude. And we'll talk about the period of time that it takes to go from 0 to the peak. We call that what? Ramp time. That's something that's real important. We'll talk about in a minute. And then again, you talk about again, this is the duration. This is the length of time that it lasts. This is the strength duration curve. I put this up here for one reason. It proves what I'm trying to tell you about with phase duration. I want you to see what happens. This is amplitude. This is phase duration. When the phase duration gets longer, what do you see amplitude doing? It goes down. So the longer the phase duration, the less amplitude you need to make a muscle contract. Guess what you just did to the comfort for the patient? You made it more comfortable because you use less amplitude. Higher frequencies, longer phase durations are more comfortable. So when I tell people if you're treating pain, 200 microseconds or less is phase duration. And if you can't see what I'm doing now, I tailor make all my protocols to the needs of my specific patient. I can then save the protocol on the device. I don't have to create it every time. Just save it, hit a couple of buttons, and I'm there. If you're really doing sensory stimulation, you need to be 100 microseconds. And then if you're doing muscle strengthening, it's got to be 200 or longer. Has to be 200 or longer. Duty cycle is the on and off time, right? If you're doing muscle strengthening and muscle re-education, there's an on time, there's an off time. There's a work time, there's a rest time, right? And Lynn Snyder-Mackler, when she did her research, she said what? The rest time should always be 3 to 5 times greater than the work time. That was to prevent fatigue. But we've already said fatigue's not a bad thing. We got to push them a little bit, right? So I never use a 50-second rest time. 30 seconds, And I'm talking about people my age, okay? We still use those shorter rest times because we want them to do work. The interesting thing is you can set those work and rest times really short too. So when we start talking about function of a patient, I want you to understand this one. If you are trying to get a patient to develop stability, in other words, we want them to stand up. My biggest problem with patients with lower extremity issues, whether it's a knee replacement or possibly a stroke or those kind of things, our goal is we always want to get them up and get them to walk, right? That's okay. We want to get them up, we want to get them to walk. That is the goal. But don't you think we ought to teach them how to stand before we teach them how to walk? Wouldn't it be a lot easier if you taught them how to stand up and how to support their weight on both feet before you taught them how to walk? We get the cart before the horse sometimes, right? And so a lot of times I will take these very long contraction times. I do this especially with like ACL reconstructions or knee replacements. I'll take a patient, and if it's the right leg, I'll tell them to stand up and put all their weight on their left leg. I'll put the current on both the quads and the hamstrings and make them both contract at the same time. If I contract an agonist and an antagonist, what did I just do to the hip and knee? I stabilized them, didn't I? So I make them both contract at the same time, and when they feel the contraction, all I ask them to do is shift their weight a little bit to their right leg. When they feel the current turn off, I go this way. When it turns on, I go this way. And you get them to do this. If you can teach a patient to do this, this becomes much easier because they're already stabilizing. So I use long work times and longer rest times to create stabilization. But once I want them to start doing ballistic movements, functional movements, I go very short, 5 seconds on, 5 seconds off. 4 seconds on, 12 seconds. But I do very short work times and shorter rest times, and that's going to give me more function. Ramp time. I don't know what kind of devices y'all have. It doesn't, that's not important right now. But you should have the ability on any unit that you use for muscle strengthening to adjust something called ramp time. That's the point that it goes from 0 to the peak. Does anybody know what most ramp times are default to on a device? There's one that does that. The vast majority of them are 2. But it will. So I want you to think about this. I'm going to throw a 4-letter word out. Forgive me. Fall. It's a bad word, isn't it? Begins to cause all kinds of paperwork and problems and panic. Do you know why people fall? If you ever get bored, you want something to read, well, I should say it this way. If you ever get insomnia and you need to go to sleep, I wrote a paper on falls, why people fall, okay? 30-some pages long. It's a great paper, boring as all get out. It'll put you to sleep, page 5, guaranteed. Do you know why people fall? It's because they can't generate force in a timely fashion. We want to blame it on all these other things. And yes, if a patient's heavily medicated, they're more likely to fall. But what does the medication do? The medication keeps their muscles from producing force in a timely fashion. I want you to think about this. I'm walking across the floor. My heel hits the ground. It's going to take my muscles 2 seconds to generate enough force to sustain my body weight. What's going to happen to me? I'm going to fall. I want you to think about when we use an electrical stimulator to teach muscles how to get stronger, we leave that ramp time at 2 seconds. We leave it there because it's comfortable. The problem is you're teaching a muscle to generate force over 2 seconds. It's not the way this works. When your heel hits the floor, you got half a second to produce force. The ramp time should always be half a second. If you're doing muscle strengthening, muscle re-education, your ramp time should be half a second. And guess what? If you have a tool, you didn't realize this, but you have a tool to teach a muscle to contract more quickly. It's called ramp time. Electrotherapy. You can teach the muscle to contract quickly and generate force more quickly, therefore keeping a patient from falling. Okay? Got a whole presentation I do on nothing but muscle strengthening, okay? So when we start looking at this and we start talking about all the NMES and looking at muscle deficit and those kind of things, I just threw this in here, and I think all of you have copies of this. So the really cool thing is that, you know, you've got some references there that talk about addressing the fact that we need to generate force more quickly, and we can do that through ramp time, and that's what makes this more functional. Any functional device has 0 to half a second ramp time. It's as simple as that. We talked about this. Electrotherapy shouldn't be passive. If you're doing muscle strengthening, the patient needs to generate force with the current. If you're going to treat pain, the patient needs to be doing some kind of movement. If you're doing functional activity, I will tell you what. You ever treat patients who just you're trying to stretch them, you're just doing stretching activities? Tight hamstrings. You want me to tell you the best way to get hamstring length? Take an electrical stim unit, place it on the hamstrings, place that channel on the hamstrings, use 2 pretty good size electrodes, turn them up until you get this hamstring to start to contract just a little bit. We don't want a complete contraction, but you actually get it to contract, and then you start stretching while it's contracting, and let it contract and relax while you're stretching, and you will lengthen the muscle more quickly. You can do your stretching in half the time. Half the time. And I will tell you that I believe this, and I do this not because I've taught this and I've done it on patients. I have been the patient myself. Okay? Here's one study, Reinhold's study. And Reinhold's study very simply talked about the use of electrical stimulation on the shoulder after a rotator cuff repair, and how they increased external rotation force by as much as 22% because they used current. This was comparing a patient with current, without current. Here's the same thing that was done earlier, except they did it on ACL patients. So look what I gave you. I'm a giving person. I'm also full of it, but that's beside the point. There's your protocol. That's a framework, okay? If you want to use a sensory gate theory protocol, that's how much, there's your frequency, phase duration, and amplitude. There's your framework, right? If you're going to do the motor, there's your frequency, phase duration, there's your amplitude. If you want to do muscle strengthening, look what I've done. We talk about cycle time, we talk about ramp time, but we talk about frequency, phase duration, and amplitude. You can adjust any. Now I'm going to tell you, when we asked which waveform do you use, there are 2 things that make you choose which waveform. Number 1, which one has the most power? And number 2, which one gives you the ability to adjust all the parameters? If you can't adjust the parameters, if your machine gives you a protocol, you put it on and you turn it on, and that's what you use on a patient, don't expect it to work. Don't expect it to work. Okay? Here's your edema protocols. There's the muscle pump, the muscle cycle, there's the ion. Notice this. The only one of those protocols that you've seen with a waveform attached to it is the ion repelling, right? Why? Because it's a DC waveform. It's the only one that will do that. AC current does not have polarity. It reverses, right? So it can't push or pull. It will do it in that fashion. If you want to stabilize and align a joint, if you want to put something together, you want to stabilize this joint, and you want to make things happen, right? Here's some tips. I want you to notice something. You see the term co-contract? Most of your stimulators have something called co-contract and reciprocal. You understand what I'm talking about, right? Co-contract means we contract 2 muscles at the same time. Reciprocal means we contract one and then the other, and we go back and forth. So if you want to create stability, contract the agonist and the antagonist at the same time. If you want to increase range of motion, let's say, at the elbow. We contract the biceps, and then we contract the triceps. So we get movement with the current, and we get the patient to move with it. And what you'll find is that reciprocal and co-contract have very specific responsibilities. I told you I hate interferential. If I had my way about interferential, it would disappear from the face of the planet. You would never see it again. You would never have the ability to use it again. It would just be poof and it was gone. If I could wave my little magic wand, that's what would happen. You know why? Because it takes 4 electrodes. It takes 2 leads, and you got to figure out where to put 4 electrodes. And I'm telling you, when Mrs. Johnson, who's 80 years old and that little tiny atrophied shoulder, and you try to put 4 electrodes there, how's that working for you? And oh, by the way, all that loose skin, and you put the electrode here, but then it drops down here because that skin's loose. Am I right? I was born at night, but it wasn't last night. How much time does it take you to set that up? How big of a pain is that with all those wires and 4 electrodes? When you know what I do? I use a symmetrical square biphasic waveform. I'm going to talk to you about it in just a minute. But I'll take 1 electrode here, and I'll put 1 electrode here. And oh, by the way, sometimes if people, what if both shoulders hurt? Or what if rotator cuff repairs? I don't know if any of y'all, I had a rotator cuff repair. The thing that always amazed me is my elbow hurt as bad as my shoulder did, right? So I needed to treat both places for pain. And so I would put it on co-contract. Now I have 2 channels, put 1 channel up here and 1 channel down here, set it up, and now turn them, and they're both working pain, set the parameters so that, it's 100 pulses per second, the phase duration's 100 microseconds, and it's on continuous, and it's just sitting there buzzing me, and it gets my elbow and my shoulder at the same time. I can treat 2 things at the same time. That's why you use things like co-contract, reciprocal, one then the other. By the way, you want to gain motion. What's the most difficult thing to get back with a knee replacement or an ACL reconstruction? Terminal extension, right? By the way, this is not a trick question. It's not a trick question, but tell me what muscle creates terminal extension. You would think the quad does part of it, but terminal extension is actually created more so by the gastroc and the hamstrings because when you talk about the screw home mechanism when the femur rotates into the tibia, the tibial plateaus. So what do? Take 1 channel, put it on hamstrings. We take 1 channel, we put it on the quadriceps, and we put it on reciprocal. And we stand the patient up. I'm one of these people, if a patient can stand, make them stand. Folks, you're in the OT world, if you're working with their hands, make them stand up to do their stuff. Okay? And I'll explain that one to you in a minute too. But the bottom line is, you stand them up, you put their weight, and when those quadriceps contract, what do? You make them try to straighten the leg, straighten the leg, straighten the leg. But here's the key. When the hamstrings contract, get them to dip just about 20 to 30 degrees. Just get them to dip and isometrically hold that while the hamstring's contracting. You're now going to strengthen the hamstrings so that when you contract, they create the screw home mechanism to give terminal extension. That's the idea. So I do these different things with the current, okay? And I'm a real stickler about making patients do things that they don't want to do, If you want to improve function, I use short times, this, that, and the other. Let me tell you a story. September of 2000, I told you this is my first time doing this in 2 years. September of 2020, I was diagnosed with a chordoma. The chordoma was on my sacrum, my coccyx. It was 14 centimeters long, it was 14 centimeters deep, it was 10 centimeters wide. February the 3rd, 2000, I had a couple of months of radiation, February the 3rd, 2020, 21, I went to Massachusetts General Hospital, where I had the first of 2 surgeries, 13 hours the first day, and I had 10 hours the second day to remove that tumor. If there was a complication that could occur, it happened to me. Long story short, I spent 30 days in Massachusetts General Hospital on my back, most of it unconscious, had no idea I was in the world, had 3 strokes. Like I told you, if it could go wrong, it did. After 30 days, they moved me to Spaulding Rehabilitation Hospital in Boston. Shirley Ryan Hospital in Chicago, Illinois is supposed to be the top-ranked rehab hospital in the United States. Spaulding is supposed to be number 2. I have taught at Shirley Ryan, I have taught at Walter Reed, and I have lived for 5 months at Spaulding, and I'll tell you, they're the best rehab hospital in the world, okay? The bottom line is, I could not walk. Damage to my sciatic nerves and all of these things, so on and so forth. I have always been a believer in this stuff. I have always known that it worked. I am not only a believer now, I am convinced. Because I'm telling you, without that current that they did on my muscles, I wouldn't be walking today. And everybody can say, oh, we could do it with exercise, we could do this. No, you can't. You gotta have a little help along the way. You know, hear the crazy thing? They didn't use electrotherapy there. Didn't even have a device. I called up one of Lewis's friends. I said, I need you to send 2 units to room 615. And they brought the equipment in and I taught them how to use it. I showed them how to do things with patients they'd never done before. I changed the way they treated things because I was a patient there. Most horrible 6 months of my life. I was 173 days straight in the hospital during COVID. Can't see nobody, can't do nothing, okay? But I had rehab for 4 hours a day, and I'm telling you, 1 hour a day of it, there was an electrical device attached to me to either strengthen my muscles or lengthen my muscles. And we did all those things, and I'm telling you, it works. It makes a difference. Did they get paid for doing that? Well, they got paid. I was an inpatient, so I guess it's a whole different billing system. But the bottom line is, it makes a difference. You just have to use it, and you have to use it correctly. So it's a funny thing to me. So they called me up the other day, says, we got some new therapists. Is there any way you can do a virtual training and do another electrotherapy training for us at Spaulding? So yeah, the answer was yeah. I want to go up there so I can visit everybody, but I am here because I'm telling you, couldn't walk, couldn't move, couldn't do any of those things, but the current is what made all the difference in the world, okay? So I'm a believer in this. For me, it's personal. For me, it's personal. How do you increase circulation? High volt. So if you want to do something with wounds, with spasm, with inflammation, the greatest anti-inflammatory you have is high volt current. You take somebody who's got some pretty severe inflammation, struggling with pain, you put a bag of ice and high volt current on them and I can help them. You know? Sometimes I don't use the ice because the ice is going to inhibit the circulation. If I want to get full-blown circulation, I just put the high volt on them and we rock and roll. Don't worry about a heat pack or a cold pack. You can use that afterwards. But I will do those things and get them to do movement with that so that I can and again, by reducing inflammation, what can I do to range of motion?
Increase it.
I make it better. I make it better. So here's my pet peeve. My second pet peeve. Electrodes. Gosh, Lewis, I haven't done this one in a while. Forgive me. I got to find something in my little bag here. First device I ever had was called a Medco sonulator. Anybody ever heard of a Medco sonulator? Ain't nobody in here old enough to know what a Medco sonulator is. This was the electrode for a Medco sonulator. That's a metal plate. And we had the infamous yellow sponge. You dip this in water, and you stuck it in here, and we had a strap. See that little thing? There's a strap with holes in it, and you strapped it around the patient. We turned that Jessie on. And then you know what we did? We got done with her. She was a patient. Then we're going to treat you. So we took this same pad and dipped it in the water again. We put it on you. And then we dip it in the water again and put it on you. How would that fly in today's world?
Oh, that'd be.
Yeah, bad news, right? Always blows me away how we look at things differently. It's kind of like when you go to the restaurant. What's the dirtiest thing in a restaurant? The menu. Put your hand sanitizer on after you order. I mean, do you think they wash those menus? How many times have you been to a restaurant and grabbed the ketchup bottle and it's so greasy it slides out of your hand? And people worried about my electrodes. You know? Then they came out with these. You remember these? Carbon rubber electrodes. Everybody thought, well, they're carbon, they'll last forever. No, they actually break down, you know, so you have to replace them. Guess what we used with them?
Sponge.
The sponge. Some of us got smart, or we thought we were smart, and we took gauze pads and we'd wet them in water and put the gauze pad underneath and stay. Because what conducted the electricity was the water, right? So then they came out with the sticky electrodes, right? And I will tell you that there are all manner of quality of these electrodes. If you want to get the best bang for your buck, order a silver nitrate electrode. If you use Durastick electrodes, which is probably the best electrode out there, get the Durastick Premium. It's a silver nitrate electrode. Most electrodes, they will tell you, will last for a period of time. These will last longer than those. And not only that, they don't break down, they deliver the current very evenly, and they don't get hot spots so you don't burn patients. So I'm a big fan. Don't buy the cheap electrode. You know, don't buy the cheap electrode. And people ask me all these questions about electrodes, you know? And sometimes I get frustrated, right? But here's the first key. Prep the skin, prep the skin, prep the skin, prep the skin. And I tried to tell them when I was at Spalding, they would take those electrodes and they were putting them on me and they would fall right off. It was because the lady that came in putting the lotion on my skin, the electrodes aren't going to stick to that. You got to clean that mess off. Oh, don't worry about it. We'll tape it on. Not on me, you won't, because you're not going to burn me. You got to clean the skin. You do not clean the skin with a little wipe. You do not clean the skin with an alcohol prep. By the way, never, ever use alcohol. It's what you were taught to use, wasn't it? What does alcohol do when it hits the skin? It evaporates. What does it do to the skin? Dries the skin. Dry skin is a resistor. You need moisture in the skin. You use hot water and a washcloth. You use hot water and a washcloth, and you got to clean that skin, you get that stuff off, and then that electrode will stick. I thought, you know, when I was showing them how to do that on me, they thought it was the most wonderful thing in the world. These electrodes stick. Clean the skin, you know. You got to prep the skin, and too many people don't do that. That's the skip point. That will cause the treatment to be more uncomfortable too. And if you're having to tape an electrode on, you're going to burn a patient. Don't ever do that. Where do you put them? Well, if the pain's right here, you have first choice is, pain's right here, I can go above it and below it. All right? Yes, you can go on either side, you know, but you know, you put the paint in between the two, but you go above it and below it. That's one of the first. The other thing you can do is you can put one electrode right on top of the paint and the other one away from it. Okay, that's pretty simple. If you're doing muscle strengthening, muscle re-education, Where do the electrodes go? They go on the motor points in the belly of the muscle, because that's where we're going to make it contract, right? And if you're going to use interferential, bless your heart. You're in the South. I know where I am. You know what bless your heart means. It means I can call you, say anything to you I want, and as long as I end it with bless your heart, we'll all go home happy, right? I could say you're dumber than a box of rocks, bless your heart, and we'll go to lunch together, right? Do it all the time. If you're going to use interferential, bless your heart, you put them around it. It's not rocket science. It's easy. Don't make it. My biggest thing with people who teach modalities is we try to make it too hard. And we do that because we have to teach a test. You know, people, when you had to take your boards at some point, and there are certain questions on your boards, and we need to make sure that what's on the boards is what we're teaching, but we forget to teach the important stuff. How far apart should you place electrodes? Well, if you get them too far apart, they don't work. If you get them too close, it's uncomfortable. We try, you know, I've heard people say at least 2 finger widths between, you know, 2 electrodes, or the width of 1 electrode in between the electrodes. I'm going, I don't know where all these rules came from, but it all is determined by the length of the muscle. With a quad, yeah, I can get one up here and up here. I can get 6 or 8 inches in between them, right? You get to the forearm, now it's going to be a little less, right? You start doing muscles in the hand, now it gets real. That's why we use little tiny electrodes, right? So again, we talk about how far apart. It's all determined by the length of the muscle and what we're trying to do. What size electrode do you use? Well, for some reason, everybody buys either 2-inch rounds or 2-inch squares. I guess that's the cheapest thing. I don't know why, but I guess they're either 2-inch rounds, 2-inch squares, and if I'm an OT, the first one you're going to buy from me is the 1.25 round, a little bitty tiny round one, right? Because that's the one I can put in the smaller places and I can do some stuff. I don't use rounds or squares because they don't flow with the muscle fiber the way I want them to do if I'm doing muscle strengthening, muscle rehab. I use 1.5 by 2.5 ovals. I use oval electrodes because you can put them the length of the muscle. If I'm doing big muscles like the quad, I'll use a 2x4 oval. I like ovals because, again, you can run them with the fiber, you can run them at angles, you can do different things with them. So I'm just a big fan of that type electrode. And again, the little round one is what I use for the hands and the face and those kind of things. And the one question somebody in this room wants to ask right now is, can you cut electrodes? Anybody thinking of that one? Was I right? Can you cut electrodes? And the answer is not today's electrodes. Back in the day when you go to the grocery store, God, let's don't get there. You go to the grocery store now, I'm going there anyway. You go to the grocery store now and you buy a can of soup. Now when I was a kid, a can of soup was about this big and it cost $1. Now it's about this big and it costs the same $1. They think they're fooling you. You're just getting less for the same money, so they're making more money or absorbing cost or doing whatever they're doing. The same thing happened with electrodes. The procedure by which they made them, that conductive layer in that electrode keeps getting thinner. And so that means it can burn through, it can break down, and you don't get as much use. And if you cut one of those electrodes that are black, the carbon electrode, if you cut that, they can tear. And if that little carbon layer tears, everywhere it tears creates a hot spot. And everywhere you have a hot spot creates burns, right? That's why I tell people buy the silver nitrate, because they do have a mesh in there. You can actually cut them a little bit, but I don't advertise it because the first thing you're not supposed to do anymore is cut that electrode, right? And OTs used to be, hand therapists used to be real specific about cutting those things and making them fit and doing stuff. Oh, we used to do that all the time. Just can't do it anymore. How many times can you use them before you throw them away? I will tell you that most of you should use them one time and throw them in the garbage because they're ruined after you use them. If you put them on a patient that has lotion, as soon as lotion hits the adhesive part of that electrode, it's done. It's toast. Throw it away. But the other thing that you need to know about is that they say 8 to 10 times. The package will have 10 times you can use that electrode. Most of them won't last that long. And if you're going to get it to last that long, You've got to wet that electrode because they're hydrated. When you open them up, they're hydrated, they stick. When you put them on the patient and run current through them, they become dehydrated, right? They become dehydrated. And now, after they've become dehydrated, they don't stick anymore. So when you take them off the patient, every time after you take them off the patient, I don't care whether you use a cup of water, you put them under the sink, just dip them in water, get them good and wet, put them back on the plastic, drop them in the Ziploc bag, and let them suck up that water. You just rehydrated them so you can use them the next time. But again, 8 to 10 uses is the limit. 8 to 10 uses is the limit. If you use those silver nitrate electrodes, you can probably you'll get 10 for sure. Probably not going to do that with a carbon electrode. So here's the question. How do we get a muscle contraction? By the way, what time is it? I don't know what.
11:28.
I got how long? I got 30 minutes? Okay. I'm going to try to talk about 15 more minutes and give you time to ask questions, because we'll get off on some tangents and do some fun stuff. Let's talk about muscle contraction and how to get a muscle contraction with a current. Because I think this is the most difficult thing we do with an electrical current, is try to get a muscle to jump. Try to get a muscle to contract. When I was at Spalding Hospital, I was sitting there, I was doing my rehab, and there's a therapist who's talking to this patient who's had a stroke and has foot drop, right? And the patient is simply asking the question, do you have anything that can help me pick my foot up? You're telling me to pick my foot up, but I'm having a hard time. Do we have anything? Oh, we don't have anything, because, and starts explaining about fast twitch and slow twitch and all this stuff. This patient's got no clue. And I'm just sitting there listening. Now, typically, I just, excuse me, can I, but I didn't. I just listened to the explanation that they didn't have anything. And the therapist took that patient back and came by and walked by and said, can I talk to you just a second? Can I explain something to you? And I explained to him, you do have something here. Here it is. This will make her foot come up. Well, but it doesn't, She starts going on. I said, no. She asked you if you had something that could prove to her that her foot can move. And you can do that because the connection between her brain, the wire is still there. It's just not connected up here right now. We got to reconnect it. And the way you do that is you create feedback distally and send it proximally to the brain. Am I right? That's the idea. And I said, what muscles dorsiflex the foot? Well, the anterior tib. I said, well, it's true. But if I take my foot and I dorsiflex if I use just the anterior tib, it also inverts, doesn't it? So the foot not only comes up, but it does this. That's not very functional. I said, so now what we do is we put it on co-contract. And we're going to put one channel on the perineals, and we're going to put one channel on the anterior tib. And I proved it to her on her foot that I could pick her foot up and move it exactly the way I wanted it to. And if I manipulated the channels, I could invert and evert her foot. And she said, never seen that before. She's at the second best rehab facility according to all the ratings in this nation, and had no clue that she could do that with an electrical current. That says something. That's sad where we are, that some of the stuff that I learned 1,000 years ago is not being passed on. It's not being used. So how do we get that muscle contraction? What do we set things on? First thing you need to do is you need to increase your phase duration. Especially with flaccid and weak muscle. Don't be afraid to go up to 300, 400 microseconds. There are some devices and some waveforms that will have 1,000 microseconds of phase duration. I will tell you, with stroke patients, if you've got 1,000 microseconds of phase duration, you will probably have to use 800 of it. But on flaccid muscle, you can make it contract. You can get it there, but the way you do it is increase your phase duration. The second thing you got to do is make sure you put your electrodes in the right place. You got to put them in the right place. People don't do that anymore, right? We just haphazardly make sure we're putting it where the belly of the muscle is, because that's where the majority of the motor units are going to be. And if you're not getting the contraction you want, don't be afraid to lift and move that electrode. Find it, and then once you figure it out, then you're good to go. You can increase the distance between the two electrodes. If you get them really close, remember the current wants to go from one electrode to the next, right? That's all it wants to do. It wants to go from one electrode to the next electrode, which is what it ought to do. But if we get them really close together, it's going to go very superficial, and it's never going to hit that muscle. It's never going to get down there where you want it to be. So you got to spread them out just a little bit, but we can't spread them out so far that the current actually, again, the current's going to take what we call the path of least resistance. So if you get them too far apart, it'll go down and it'll jump on blood flow or something like that, travel the vessel and come right back up, and you'll miss the motor point completely. So you got to be careful, but you got to increase the distance. Make sure you use the right size. If you're doing a quad, you use a 2x4. I'm not big on 3x5s. Everybody gets the idea. Everybody gets the idea that if you use a bigger electrode, you expose the tissue, the muscle motor units. You've got more exposure because you got more coverage, right? The problem is, the bigger that electrode is, the more power you have to have, because you're spreading it out over that entire area. That makes it difficult, okay? So I limit, the key is, it's kind of like the difference between the shotgun approach and the rifle approach. The rifle's very pinpoint, the shotgun spreads. In the case, but you don't have as much power, you don't have as much distance. You got to do the same thing with an electrode. Use the smaller electrode, target the area that you really want to make contract, and you can make it happen. Too many people with muscle strengthening, muscle re-education use electrodes that are too big. The last thing that I want you to think about is I want you to think about something called VMS. I don't know if any of you have a Chattanooga stimulator at your facilities if you use that. If you have something called a Genesis unit, which is a blue and white unit, or if you have something called a Neo unit, you have something called VMS. VMS is no big deal. It's called variable muscle stimulation. You know what that is? Marketing, okay? All that is marketing. That's a title for something. But it's interesting, and this is where I want to spend a little time. It's a symmetrical square biphasic waveform. By the way, what is the difference between a TENS unit and an NMES unit? Afraid to answer that one. What's the difference? TENS units for what? Pain. NMES unit is for muscle contraction. Who told you that was the case? Who told them?
The book.
Actually, the manufacturer did. So 1,000 years ago when I started in this, the only waveform we had was high volt. I remember when IFC and Russian were approved in the United States. Okay? I remember when I got my first, oh, this is like Christmas, we got something new. But the bottom line is all we had was high volt. And all these other waveforms came in. And then all of a sudden they stopped making, they not only did they make a clinical device, but they started making these little devices. And they called them TENS devices to treat pain. And then they said, well, wait a minute. They're buying these little things like crazy. Why don't we build one and call it an MES unit? I will tell you that typically a TENS unit has a symmetrical or an asymmetrical biphasic waveform. Okay? Typically, it's an asymmetrical biphasic waveform. Now let me ask you the question, can you get a muscle contraction with a TENS unit? Sure you can if you turn it up enough. Sure you can. So could you do muscle strengthening with a TENS unit? Absolutely. But then they came up with the NMES unit and they said, well, it's got to be different, so we're going to put a symmetrical square biphasic waveform on that. Can you treat pain with an NMES unit? If you can adjust phase duration and frequency, you can. Waveform's not important, it's the physiological response. But what a manufacturer decided to do was to make 1 unit for pain and 1 unit for muscle strengthening so that you had to buy 2 units. Salespeople would probably shoot me for all of this. But the bottom line is, it doesn't matter which waveform you use, you set the parameters correctly, you can get a muscle contraction, you can treat pain, you can do any of those things. The unique thing about TENS units is most of them don't give you the ability to adjust all the parameters. So you can't, it's all continuous. So remember, with an NMES unit, you gotta have cycle times. So they had to add cycle on and off stuff or a hand switch that they don't have with the TENS unit. So that's the difference. And that's why TENS units are pretty cheap and NMES units tend to be more expensive. But this VMS thing, this is a symmetrical square. This is what we talk about trying to get a muscle to contract more completely. There's something unique about this symmetrical square waveform. Can anybody tell me what it is? See that? Remember that other waveform? It went up, it came down, it went straight down, you know? Here, before we go negative to positive, we come back down to the baseline, but before we go positive to negative, there's a delay. There's a pause. There's a 100 microsecond pause. Now that's very, very short. The interesting thing is the muscle doesn't realize that. Here's the interesting thing is, it's called an interphase interval, okay? And so when we talk about it, anytime we stimulate a muscle to contract, what do? You know, it's got to contract, it's got to relax. And we know that we depolarize the tissue. There is a period of time that it takes for it to repolarize before it can fire again, right? We talk about refractory periods and all that. I don't want to get into all that mess, it's too boring. But the bottom line is, when we talk about, when we're trying to get muscle fibers to contract, what we're talking about is we finally get to a point to where things are so close they don't repolarize quickly enough and we can't make it contract again. Or the other thing that will happen is that we will fatigue and it takes more energy to contract, and eventually we lose the ability to contract because of the fatigue we produce. So the idea behind the interval was simply this. Number one, it's more comfortable. Number two, it allows us to, because of the way we can construct the two squares, we can develop a little more power. And number three, we can possibly reduce fatigue because we're shutting it down in between the middle of the two phases, right? We're shutting it down. So here's the problem. I can throw that up there and I can make all those claims and I can tell you that's what happens. But to get you on board, what have I got to do? I got to have some research to back this up. Here's an interesting thing, and this is the guy you need to look for right here. He's actually done 2 more subsequent studies. He did one in 17 and one in 19. But the bottom line is, Dr. James Ballou is the guy who's done all the research. And here's the interesting thing. This is what a Russian waveform. Now, most of you guys, if you're doing muscle strengthening, muscle re-edge, you're using Russian, aren't you? If you're doing it, you're using Russian. Russian is cruel and unusual punishment. It hurts. It hurts. People don't like it. They don't tolerate it. If they don't tolerate it, you can't get a muscle contraction. If you can't turn it up to get a muscle contraction, you're wasting your time and you give up. Again, if you're going to drive a nail, you can use a nail gun or you can use a hammer. Which one's going to get there first, right? Which one's going to be the easiest? And Russian current tends to be the old-fashioned hammer where you're driving it in and it's uncomfortable, okay? Notice this. Russian is that burst, so you get this hoop wave. Notice the amount of power here and here, the amount of current density that you lose when you use Russian versus a square. Make sense? So you use Russian versus the square. The other thing that's interesting about this, if you look at what one pulse looks like here, you don't have any, you're not getting this time. So the fatigue factor is much greater. So what Dr. Ballou did is he took Russian current and he put it on somebody's quadriceps. He tied their leg to an isometric or an isokinetic device, a dynamometer. And what he did is he turned it up to a certain point, and they determined what the milliamperage was that they wanted to go to. They turned it up to that point and they looked at how much force they produced on that dynamometer while that patient was contracting with the current alone. And what they found out every time that when they used that VMS, that the forces produced were significantly greater with VMS than they were with Russian. Then came the next question to the patient. So if we used, let's just throw out bogus numbers, if you use 20 milliamps of Russian and 20 milliamps of VMS, they found that VMS produced greater torque forces. The other thing was they would tell, the patients then would report to them which one was the most comfortable. And something like 98% of the time, the patients all said that VMS was more comfortable. Again, and they were comparing apples to apples because they were using the same amount of amperage. They were doing all those kind of things to make things happen the way they wanted it to. So this VMS, if you have it, now I will tell you right now, Dr. Ballou has done 2 subsequent studies. The other thing he has found is that they have increased the metabolic rate of that muscle tissue. They have done some imaging things, some crazy stuff, and that they have showed that the VMS current actually increases circulation, increases metabolism, and does things in all those tissues. He's got some really cool stuff that he's done now. He's now actually doing some work with active muscle where he's actually doing some measurements with the current while the muscle is working. And so he's doing some pretty cool stuff. The cool thing about VMS is that you have that co-contract and that reciprocal. You can do a single, but you can do co-contract, you can do reciprocal. So I can do all the things I talked about, plus I can treat pain with it because I can adjust all the parameters. There's the key. I can adjust all the parameters. Plus you can have a hand switch with it. I think the one thing that is most important when it comes to muscle strength and muscle re-education, that you have the ability to do the reciprocal and the co-contract. There's no such thing outside of Bioness and some of those kinds of things. There's no such thing as true functional electrotherapy, okay? It's not ever going to be truly, completely, absolutely functional. What we have in a clinical device is nowhere near functional, okay? But I will tell you that with reciprocal and co-contract, we can create movements that lead to functional. That's my goal, is I want to lead to functional, if that makes sense. This is one of Dr. Ballou's articles, and again, he's done quite a bit of stuff. This guy's been lecturing about VMS since it was released. And the funny thing is, this company that I now work for, I've known Dr. Ballou for years, they had no idea this guy existed. And he's out there carrying water for them, and they got no clue, you know. This is one of the last ones they did in 17, where he actually showed that the isometric forces were significantly greater, and that's a crazy thing. He doesn't just say greater than, he says significantly greater. So he had very high increases. So here's the question. What do you use electrotherapy-wise? What do you pick? What do you choose? How do you make decisions? Make it easy, folks. Am I treating pain? Am I making muscle contract? Know where to turn the amplitude up. Know where to set the phase, duration, and the frequency, and you've got it whipped. You can set it up quickly. You can save protocols on a machine, so you're only pushing a couple of buttons. You hook them up, you turn them up. Now, by the way, I've said this before. You turn it up, and I'll do this with patients, and they'll say, oh, you know, you turn it up, and tell me when you feel it. Okay, you got it. Now I'm gonna turn it up till I get a muscle contraction. And you don't never say, tell me if this hurts, right? Because if you ever say, tell me when this hurts, or tell me, if you ever say any of those things, the first weird thing they feel is pain, and they'll, no, stop, you know. Just the first thing you do is, tell me when you feel it. Okay, I'm gonna try to get a muscle contraction now, and now I start turning it up. If they feel something that they don't like, they will tell you. You don't have to prompt them. They'll tell you. So you turn it up, and when they say stop, oh, you don't like that. Okay, well, can you handle it where it is? I think I can handle it where it is. Sometimes where you may have to back it down a little bit, and you're not getting the contraction you want. And so now, every time you feel the current, I want you to contract. Let's say we got it on the quad. I want you to contract the quad. Every time you feel the current, contract it, contract it, contract it. And I'll let them do about 2 contractions. And I just reach right over and turn the machine up, and I don't say anything. You want me to tell you when it's easier? When they're in the middle of the contraction. You know, and you always have to turn it up in the middle. But if you turn it up in the middle of the contraction, when they're paying attention to what they're doing and not what you're doing, you sneak right up on them, hit them in the back of the head. They don't know it. It's real simple. And the next thing you know, you've got a current contracting the muscle, and they don't realize it. So you've got to work with the patient and you do those kind of things. How many times a day or a week can you treat people? How many times can you get them? In some facilities, you have a captive audience. I was a captive audience. People in long-term care facilities are at captive audiences, right? You can get them as, I know you have multiple patients, so it's hard to get them as many times as you like, but I will tell you this. Of all the research on all the modalities that's been done, the one thing that I see consistent when they reproduce research is that the first time they did it, they were basing it on treating somebody 3 times a week. And then the next thing you know, when they're doing it recently, they're basing it on treating a patient 1.5 times a week. Did you know that's what we've come to? We've come to the point that we're now not treating 3 times a week, we're now 1.5 times per week. Why? Because insurance won't pay. Okay? But what we have found very simply is that when you're working with this patient 3 times a week, we get a result, and then all of a sudden they do the same study exactly the same way, and because they're treating 1.5 times a week, we don't get the same result. So there is something to be talked about with exposure. So we have to talk about exposure, and then there's electrode placement. Contraindications. Do you know there's a lot of things we do with electrotherapy now that are still listed as contraindications? Can you use electrotherapy on a patient who has a pacemaker? Huh? You have? Oh yeah. Sure you can. As long as it's not a demand type or a response type pacemaker, you can, they claim you shouldn't use it on that. But you got to be commonsensical, don't put it on the chest. Right? But there you have it. Defibrillator's the one that is still an out. If they got the defib unit, that's the one that we're just not willing to say you can or you can't. How many of you would put electrotherapy right here? They do it all the time with a product called VitalStim, and it's a product that teaches people how to swallow again. It's the VMS current, by the way. It's a low-grade electrical current. You never use your big clinical unit because that's too much power. They've powered the thing down for this because they're little tiny muscles, but you can contract and we can teach people how to swallow and eat again. Happens all the time. One of the most amazing things I'm seeing. If you're pregnant, would you let me put electrotherapy on you? Yep. They do it all the time in labor and delivery. Put it right on the low back to control. They're actually using it to control Braxton Hicks contractions now. So they're doing some of that. So that's some different things. Would you use electrical current on a patient who has cancer? I use it. I just told you. Now, you don't put it where the tumor is or was, right? Most common question in long-term care, Mr. Johnson has prostate cancer. Can I use electrical current on his quad? Absolutely. Just don't put it on his prostate. I don't know why you would do that, but don't do it. Right? How many of you would let me put electrotherapy right here? Do you know they're doing all kinds of studies at the Shepherd Center in Atlanta right now? They're doing some crazy stuff, and they're actually doing placements with electrodes. There's actually a couple of really good studies where they're controlling insomnia, depression, and other things by using transcerebral DC current, like iontophoresis 4 milliamps. They're using really low powers, and they're using stuff around the head, and then they're getting some results. They're doing some crazy things. Here's my email address. There's my phone number for what it's worth. I will tell you, I'm tired. First time I've stood and talked this long in a long time. But I'm able to do it because somebody was willing to do something that I asked them to do. They didn't want to do it. They would not have done it had I not forced them to. I mean, I'm the patient. I want my money's worth kind of thing. And I will tell you that this stuff works. What questions do you have? What do you want to know?
How do we get a new machine?
We have an ancient machine.
What do you have?
Oh, God.
It's a Chattanooga one, but yeah, it's ancient.
Talk to that man right back there. He can help.
This one.
Oh, dear goodness.
What's it look like? I might have the same one.
It's the old Intellect, the little flat white one.
It's really fun.
Can't get parts to fix it anymore. That's what happens. So when it breaks, you got to get a new.
The ultrasound head just broke. Yeah.
Okay, so you can no longer get parts to fix that. You got to buy a new one. That's the way you do it. Just helped you out.
Sale.
Yeah, that's the big thing. And I will tell you, you really ought to look at what these guys have here at the school.
Yeah, well, that's what we learned.
Yeah, they got the Neo with the big touch screen now. Yeah, that's my baby. I have 3 children. I have a 33-year-old son, a 30-year-old daughter, and that Neo. And I think I lost more hair with the Neo than I did with the other 2. But yeah, that's a great piece of equipment. What do you want to know? Anything, any questions? And I'm sorry, today I've done this lecture. Gosh, Lewis, how many times have I done this? Hundreds of times I've done this lecture, and I've done it all over the place. And I always speak from the clinician's point of view. It's the first time in my life I've ever been able to speak from the patient's point of view, and I don't like it. Don't get me wrong, I don't like what had to be done to me. I didn't like. But by all rights, I shouldn't be walking. Just to show you, I lost 75% of my glute muscles, the glute max, and they took my glute medius on my left side. They took my sacrum from S3 down. So, by all, I shouldn't, but I can, because people allowed options to occur to help me to create muscle contractions and do things. So stuff works. I tell people all the time, I've seen this, I've done this, but then you do it to you, it takes on a whole nother meaning. And it's pretty cool stuff. The other thing you folks need to look at, the latest, greatest in modalities, is now called extracorporeal shockwave therapy, ESWT. And there's something called focus shockwave, and there's something called radial pressure wave. I've been teaching modalities for 40 years. I've been teaching since 1982, so I've been teaching for 40 years. And I will tell you that I've never seen a piece of equipment that just gets results like you've never seen before. Have a guy with Dupuytren's contracture, those 2 fingers pulled down just like that. I treated him twice and he's here. He's not full extension, but I've treated him twice and he's short of extension, but that's treating twice. So you need to take a look at some of this stuff now and this newer stuff that's coming out. The shockwave, focus shockwave it's amazing the results I see with that.
So what's the different waveform of that?
It's acoustic energy. So it's lithotripsy. You're familiar with lithotripsy, and they use a sound wave to break up a stone? What we do is pare that energy back, so we use lower levels. Instead of creating a destructive mechanism, we create a mechanism that disrupts the tissue matrix and very simply creates a subacute response. I mean, how many of you guys use needles, cupping, or Graston tools? What's your purpose? Your purpose is to create another injury. You create another injury so that you create inflammation so that you get the tissue to try to heal, right? That's why your patients wind up with ecchymosis and pain, and they're black and blue, and you get some pretty significant side effects from that. I can take this shockwave device, and instead of going into a full-blown acute situation, I can go into a subacute situation. And the crazy thing is, I don't get the black and blue, I don't get the redness, I don't get the swelling, I don't get the problems. I may create a little more pain for the patient, but the insane thing is, I'm seeing things. I just spoke to a therapist in New York City the other day who has a practice somewhere downtown New York City, and her thing is pelvic floor specialties with women and incontinence. She is literally using a focused shockwave and a radial pressure wave. She is treating pelvic floor, and they are getting phenomenal results. And the best we can figure, this device actually causes new blood flow, angioneogenesis, new blood flow. It'll cause myogenesis. And what they're actually seeing is, because you disrupt the tissue matrix and you reboot the inflammatory process, they're actually seeing with myogenesis, they're seeing where the sling is lax, they're actually seeing it tighten and the scar tissue go away. So it's insane stuff, but it's some of the newest thing going on. What do you want to?
Do you ever educate like doctors?
Sure. If I ever get the opportunity, I would love to.
I feel like they are, I know when I worked in outpatient, they had no clue what any of this was. But they definitely would not let us do it on somebody that had cancer. We would call and ask them. No.
There are many times when people call me and the docs will say, and they want me to put something in writing or do those kind of things. We sometimes will do that. The company is not real big on me doing that,
Right.
because it creates the possibility of liability, and I keep telling them, it's no liability here. You're not,
Yeah.
I think it is a lack of education. I think it is a problem, and I'm always willing to talk to a doctor and tell people, if they want to call me and talk to me, or if they want me to call them and explain to them, I'm always glad to do that. Because you're right, that is part of the problem. They'll PRN everything, but no, you can't do this, right? And so sometimes I get them in a room. Most of the time when you get them in the last doctors I had in a room, the new thing is now, of course, everybody's worried about sexual dysfunction, male and female, and whether it's, erectile dysfunction, Peyronie's disease, or all these other things that occur. They're now, if you see these advertisements on TV, by the way, the device they're using is the shockwave device. That's what they're using to treat people with. And so you get doctors in a room for that because it will make them money.
Yeah.
They won't talk about this much. And most of the time, some of the newer doctors have been a lot easier to convince with the electrotherapy than the old. It's the old guard, because it's the old stimulators. And one thing about us old guard, we're going to retire. So
Okay, you said in the beginning you had all the list of all the things that you like to use, and I know VMS was one of them apparently, but what was
there are two waveforms that I use, high volt and VMS, that's it.
Okay.
I use high volt and VMS. I use VMS to treat pain and do my muscle strengthening, muscle re-education. I'll do it to do muscle contraction to move fluid, but when it comes to reducing spasm, I use high volt when it comes to increase circulation or to move fluid. I'll use high volt.
Yeah.
The other one that I may use occasionally, there's something called Hahn stimulation, but there's no adjustable parameters to it. All it is a TENS unit. It's an asymmetrical biphasic waveform that starts with a really fast frequency, and then it goes real slow, and then it goes really fast, and it goes real slow. I'll use that to treat pain sometime and get people to do movement with it because they tend to tolerate it a little better. It's a little more comfortable. But yeah, I only use the two. I don't even, if I had my way about it, we'd build a unit that only had certain things on it, you know, but the problem is people still use interferential, and I don't, I like to ask people this question. Interferential came to the United States in 1970, was it 79 or 80? Can't remember, it came 79. How many of you still drive a car from that era? There's a reason you don't. Because technology's changed and things are better. And now, unless it's a muscle car that you've redone, that's a whole nother ballgame.
I use interferential because when I have used it, my shoulders or back is sore and somebody has strapped that on, did IFC on it. It feels so good afterwards, I'm good for days.
Yep.
And so that's why I use it on my patients at the end of treatments. So like I might use some other electro things like
Well, start thinking about using it. Start thinking about using it beforehand with the movement, with the things. And again, I'm not big on the interferential because I don't want to have to hook up 4 electric. You can get the same response with any waveform. The great thing about VMS is more comfortable than is interferential.
try the VMS.
Yeah, give it a shot. I think you'll. I don't think you have it on that unit.
No, I don't work.
No, yeah, you don't have it on that thing. Lewis can fix your problem. I can't fix that problem.
So if we don't have it on our machine and we can't really get a new machine, I think this is the one I have.
It's blue and white, isn't it? It's on there.
Oh, it is? Okay, good.
Yes, it is. There's one thing that says VMS, VMS burst, and it should have VMS FR on it. So for any of you who have ever used ACP devices, the VMS FR is an improved version of PINS. And I teach a course on that too.
I like the ACP ones because it's not, everything's already set up in there.
One size fits all.
Train you.
One size fits all. Just push a button, put it on, and turn it on. One size fits all.
Yeah.
Come on now.
I had really good results with the ACP doing bladder control.
I can believe that.
With the rheumatoid arthritis.
Yeah, I can believe that. But again, my problem is I can do the same thing with anything else, but now I can tailor make it to my patient and get the results I want.
Right.
Because it won't work for everybody.
If you're not good with the big words and all of the stuff.
You don't have to be good with the big. That's why I'm telling you. Frequency,
Lost in there somewhere.
frequency, phase, duration, amplitude, and I left you every protocol. It's easy. Don't make it harder than it.
I'm a hands-on
It scares people. Here,
All these big words.
you see that phone number up there? Oh yes. I got to hand these out. See that phone number up there?
Yeah.
Pick up the phone and call me.
All right.
If I'm not doing what I'm doing right now, which by the way, anybody work at Encompass? I'll be here next week. I'm going to 2 Encompass facilities next week.
Which one?
Louis, where are we going? We're actually going in. Huh?
Wrong one.
I swear that sounds familiar, but I don't know.
Birmingham?
Yeah, they're both right here close to Birmingham.
Shelby County?
That's the other one. I believe you just hit them both, but I'm not sure. Lewis has the. But
Lewis,
yeah.
this is a different one because this is pelvic floor. He
Uh,
talks about pelvic floor.
That's the one they
He did
gave
for.
us.
that's the one they gave us.
Okay, I got all y'all's right.
That was in my folder. Wait a minute. Did that come out of my folder or the other guy's folder?
Oops, sorry.
Where's my folder?
I don't know. Where's your folder?
I don't know. Oh, here.
He's
Where's your
supporting
folder?
it. Take 2, right? Okay, so
I'm
this
sorry.
is
Yours.
That'll work.
This is, and what is on the 12th floor?
Do you have any more of these, or can you email it? Because mine was missing like every other page.
Is it really? You see that email? You see that email address? Email me, I'll send it to you. Okay? Folks, if you want protocols, like for your machine, I have a list of protocols that are adapted specifically to that unit. I will send you the list and you can put them all on the machine, and then it's one button push and turn it on, and you can adjust little things if you want. I'll send whatever you want.
And so just email.
Yeah, email me. Just tell me who you are and what you need, and if I can get it to you, I will do it. I promise. You're welcome. Good luck to you.